Mentor's permission, we shall begin the session.
Yes, ma'am. We'll start.
Informant patient himself and his mother. Patient XYZ, a 19-year-old right-handed Hindu male patient residing in Gosunda village, district Chittorgarh, Rajasthan, was admitted to neurology ward on 26th October 2021 with the chief complaints of difficulty in walking for 10 years, clumsiness in hands for 5 years, slurring of speech for 5 years, and deformity in left foot followed by right foot for 3 years. Patient was apparently asymptomatic around 10 years back when he was studying in 3rd standard. Like other children of his age, he was able to do all the daily activities by himself with average school performance. He used to go to school by walk and he was good in sports, which included running and cricket. He then noticed difficulty in walking because of imbalance, which was insidious in onset and gradually progressive, associated with swaying in all directions, and with occasional falls, which led him to stop playing sports. Over the year, his mother noticed he started keeping his feet wide apart, both in standing and while walking. 6 years later, patient also noticed difficulty in walking without looking at the ground. He gets scared to take steps without eyes on his foot, which was not so before. He had difficulty for walking in the dark and has history of falls during washing his face several times. Eventually, walk has become more unstable such that frequency of falls increased over the last 1 year, and now is scared of going to heights like terrace of his home because of the fear of falls. However, patient used to feel the presence of slippers on his foot and the nature of floor once he places the foot on it. Patient has difficulty in wearing slippers and then walking with gripping them, which used to improve when he used to look at it while wearing and walking. There is no slippage of slippers. Patient has not sustained any serious injuries during falls as he used to take support of his hands, and he also used to get up by himself immediately after falls. There is no history of giddiness, lightheadedness during the falls. There is no history of change in hearing, ear discharge, nausea, or vomiting. And there is no history of any difficulty in getting up from squatting position, getting up from bed, or rolling over in the bed. Patient developed clumsiness in his hands from last 5 years, which initially started by difficulty in gripping the pen, and because of this, his handwriting slowed down. He was unable to complete his homeworks during the 8th standard. Later in 9th standard, he got failed as he was unable to write the answers despite knowing them. Subsequently, he lost interest in his studies and did not reappear for the exam. Clumsiness also progressed to affect his routine activities like buttoning and unbuttoning of the shirt and breaking roti into pieces, which he is managing by using both of his hands. However, patient has no difficulty in combing, using mug during bathing, and reaching objects over his head, but slight clumsiness was persistent even then. Patient also developed slurring of speech from the last 5 years associated with slowing of speech and frequent gaps between syllables, and also there was undue stress on the words spoken. However, patient was able to understand, read, and also the speech content and meaning is good. There is no change in voice or nasal twang. There is no regurgitation of food, no preferential difficulty in uttering any syllables. Patient noticed increased upward curvature in the left foot 3 years back, a year later in the right foot, which gradually progressed such that all his friends and relatives began to notice it easily. There is no history of tingling or numbness or any burning pain in the limbs. Patient was able to appreciate the presence of cloths and hot and cold water while bathing. There is no any history of injuries or burns in the extremities. There is no bowel and bladder incontinence. There is no history of pain in the eyes, decreased vision, double vision, visual loss, or drooping of eyelids. There is no history of band-like sensation of the chest or abdomen. There is no radiating shock-like pain on bending neck. There is no history of altered behavior, impairment in memory, loss of consciousness, or abnormal body or limb movements. There is no waxing or waning of symptoms, and there is no history of abnormal sweating or palpitations, and there is no history of easy fatigability or any history of blood transfusions. And there is no history of loss of appetite or weight loss, no history of abnormal taste or smell sensation, no history of deviation of angle of mouth or drooling of saliva, no history of nasal regurgitation, and no history of decreased or abnormal hearing, and no history of no difficulty in chewing food and swallowing. Past history: for the similar complaints, patient has consulted multiple hospitals where his MRI imaging was done and was given multivitamin tablets. but there was no any improvement in symptoms and his illness progressed. And there is no history of diabetes, hypertension, thyroid dysfunction, tuberculosis, or epilepsy. Birth history, he was first of the 2 live children born out of non-consanguineous marriage, born by normal vaginal delivery. It was a home delivery, immediately cried after birth, and there was no admissions immediately after birth. He was breastfed for up to 2 years. He was not vaccinated according to national immunization schedule. However, he remembers taking oral polio drops at his school. Family history, father mechanic by profession, formal education up to 10th standard, earns 10,000 per month. There is no similar complaints and no other medical illness in. Mother is housewife, illiterate. There are no similar complaints in her and no other medical illness. Age of mother during the first childbirth was 24 years. He has a younger brother who is 17 years old. He is currently in 11th standard. He is good at studies, average student in his class, and there is no similar complaints in him. His pedigree chart, man. Both the grandparents from both the paternal or maternal side, they were not having any complaints, and his father was the third among all the. He has 2 elder brothers and 1 younger sister. None of them have any complaints, and his mother has a younger brother. He is also not having any complaints, and he is the first child of them who is having these complaints. He has a younger brother who is not having any complaints. He is the only member in the whole family who is having these complaints.
Now we'll try to localize. First, we will go to the symptoms, each one will analyze, then we will decide. First, you said that he was normal up to the age of 10 years, 5
years.
5 years. Okay, the first symptom was he was unsteady, no?
Ha, ma'am, difficulty in walking. Imbalance was there.
Okay. So that's a gait problem. So apparently it is a gait problem. First thing is a gait problem.
Yeah.
So how do you like to localize that gait symptom this patient had? So if you want to elaborate on that gait symptom, you clearly told that he could clear the floor. I understood that we analyze gait by briefly. We will ask when you tell history. Of course, you have told all the points which we told, but little more elaboration we will do in anybody in this age group. They will have many other issues which can produce gait problem. Yeah. So whether he has any pain.
He was not having.
So that quickly I am telling, when you tell, it is better so that we don't miss another case. Child will fall, they will develop epiphyseal necrosis. So they will have a limping gait. So whether there is a pain, whether there is any short limb, whether there is any swelling, one brief. So this is a gait anomaly. So when you analyze gait abnormality, not this case, any other case. Yes. So whether there is a painful gait, whether it's a short limb gait, or whether there is a swelling anywhere, none of those things are there. So then next thing we do is anti-gravity stretch, stepping, equilibrium, propulsion. So if you analyze that symptom, according to what you have told, anti-gravity stretch part is all right. It is not affected. He is able to clear the floor.
Yes, ma'am.
And stepping part probably is all right. He must be, he is not dragging. So if the stepping part is affected, the patient will drag. So he is not dragging. You told that he is having a wide base.
Yes, ma'am.
And a wide base, and he is swaying to either side. So
all
it's
the sides.
Equilibrium part. So it's the equilibrium part of the gait that is affected. And naturally, when the equilibrium is affected, the propulsion will also be affected. So this person presents with the gait cycle problem, which does not appear to be due to any peripheral executive apparatus defect. Instead, it appears to be in the phase 3 of the gait cycle, where the equilibrium is affected. When the equilibrium is affected, propulsion will also be affected. So when you take propulsion, you are told that, so it is a phase 3 equilibrium.
Okay.
Would you like to analyze that equilibrium part, like your exam assessment? Quickly, if you want, you can assess.
Equilibrium is maintained by mainly cerebellum, ma'am, and then proprioception and vestibular system, ma'am.
Yes.
Vestibular cerebellum, vision, and proprioception. These 3 sensory apparatus are important for maintaining the equilibrium.
So how will you differentiate all those 3 things? As you clearly, and you have got a pseudo-ataxic syndromes, which we call as one is the waddling gait. So many people who have a waddling gait, they
Myopathies.
also say they are swaying because they are having this Trendelenburg effect. So each hip will dip, and so some of these people with CIDP also are mistaken as cerebellar ataxias. So one is the classical equilibrium where it is cerebellum, proprioception or vestibular system. And second is the pseudo-equilibrium syndromes, which is due to proximal weakness, either due to radiculoneuropathies or muscle diseases. So that part, it will not be a side-to-side swaying. It will not be a broad base. They will not reel. But instead, they will, if you clearly ask, it will be a waddling gait that you can ask. It happens at the level of the pelvis. Whereas the other coordination problems involves the whole body. It is not happening at the level of the pelvis. Even though they say I am waddling, I am swaying, the thing is actually at the pelvis level. It can also happen with dislocated hips, chronically dislocated hips. So that will be very clear if you ask them. It's the lower body that is swaying, and there is no broad base or there is no side to side. So it is clearly not due to the pseudo-ataxic syndrome. So it can be cerebellar, vestibular, sensory. How will you differentiate all this now?
It is if it is vestibular, patient will be having associated auditory complaints, and there will be other complaints like nausea, vomiting, lightheadedness, or other vertiginous complaints will be there, ma'am.
So you will get other vestibular complaints, no?
Yes.
If it is vestibular, why you should get auditory complaints? So if it is vestibular, you will get other vestibular symptoms. They will be the dominant ones, like as you said, vertigo,
yes,
vomiting, and vestibular type of nystagmus you may find.
Might be there. Yes.
And what else you will find? An acute vestibular syndrome. Let us imagine acute vestibular neuronitis. No?
Yes.
What will be the feature?
Nystagmus swaying with unilateral side. Usually, if it is unilateral, then unilateral swaying will be there, ma'am. If it is unilateral,
and so it is usually unilateral.
Yes.
Then
associated nystagmus will be there, ma'am.
Yes.
And patient will be having severe dizziness.
Patient has a vestibular symptoms like vertigo, vomiting, you have told. Second, it will be unilateral. Third, they will have a side of preference.
Yes.
They will like to lie down with the affected side up. Yes. So affected side up will be the comfortable position to reduce the disequilibrium associated. And then they sway to the same side, and the environment will spin to the opposite side. So the patient will be swaying to the side of disease. Environment will be spinning to the side opposite to the side of disease. Then when you examine the nystagmus of vestibular nature is horizontal and rotary with a slow component to the side of disease. So whenever you are looking to the right or left or whichever direction, the slow component of the nystagmus will be in the side of disease. So that is vestibular. Then come to cerebellum.
Yes.
In cerebellum, which all parts can produce imbalance? One, it can be in the cerebellum itself, or it can be in the connections. No?
Yes. Yes.
So in the cerebellum, which part of the cerebellum produce imbalance?
Flocculonodular lobe can, and
then,
Vermis anterior Vermis can produce imbalance.
Yes. So how will you differentiate flocculonodular lobe and Paleocerebellum mainly? And Vermis also has got some imbalance. That part of it we will analyze one by one. So now let us see what will happen if it is flocculonodular lobe.
If flocculonodular lobe, ma'am, there will be severe ataxia, ma'am, associated with the reeling while walking, ma'am, and associated nystagmus will be there, ma'am. Either
so flocculonodular lobe closely resembles vestibular neuronitis, but it will differ in the sense that it is a primary lesion involving the flocculonodular lobe is usually bilateral. Yes. The nystagmus will not have the slow component of the side of disease because it is a central process. Yes. So otherwise, vertigo, vomiting, and severe reeling type of gait. So it's not a swaying gait, it will be reeling. They will reel through a wide arc like a drunken gait. Yes. So flocculonodular lobe closely resembles inferior cerebellar peduncle and vestibular nucleus. So flocculonodular lobe, inferior cerebellar peduncle, and vestibular nucleus closely resemble each other. The point to differentiate will be the vertigo will be slightly less. There is no side of preference in which your symptoms are less, and the symptoms are generally bilateral and you reel to either side. So that is the point to differentiate flocculonodular lobe. As you clearly said, it is a gait ataxia of reeling type associated with the vestibular type of nystagmus. Then second site of the cerebellum is Paleocerebellum. Anterior vermis we will come to. Before the Paleocerebellum, that's the anterior part of the cerebellum. What will be the type of ataxia you get in anterior lobe of the cerebellum?
Here also there will be ataxia on which
Yes.
can be swaying on either sides, but there won't be reeling gait, ma'am, compared to
Yes. So it will be a general side to side swaying.
Yes.
There is no vertigo, there is no nystagmus, only gait ataxia. It's a gait ataxia without any accompaniments. That is the Paleocerebellum. Next come to the vermis. What will be the typical features in vermis, ma'am?
Along with mainly axial ataxia will be there, ma'am, like truncal neck ataxia will be there, ma'am, like titubations might be there, ma'am. While patient sitting also, patient cannot maintain that posture.
So it is mainly a truncal ataxia with titubation and overflow to the leg. So it will be mainly not a limb ataxia. It will be a truncal ataxia. The trunk will be wobbling on the limbs and they will have titubation. That is vermis. Then you come to the peduncles. Inferior cerebellar peduncle, we discuss it closely resembles flocculonodular lobe and vestibular system. Supposing you have additional features which involve the medulla, because inferior cerebellar peduncle comes from the medulla. If there are associated lower cranial palsy, something like that, then you may think that it is coming from the inferior cerebellar peduncle. Otherwise, it is very difficult. It closely resembles, exactly resembles vestibular nucleus. Additional brainstem features involving medulla only will help. Then next will be the middle cerebellar peduncle and superior cerebellar peduncle. Before that, just for your exam purpose, would you like to tell the afferents and efferents of the inferior cerebellar peduncle? What are the afferents? What are the efferents? Grossly.
Vestibulo-cerebellar afferents will be there from inferior cerebellar peduncle, man. And then cuneo-cerebellar afferents, man.
So efferent is mainly vestigio-bulbo-vestibular. So it is vestigio-bulbo-vestibular pathway, that is the main efferent. The afferents are mainly the olivocerebellar, vestibulocerebellar. Mainly it is the olivocerebellar and the vestibulocerebellar. Then you come to the middle cerebellar peduncle. What is the peculiarity of the middle cerebellar peduncle?
Mainly it
does it produce ataxia? Does it produce ataxia? It does produce, no?
Yes.
That is the only area where the corticospinal tract and the cerebellar tracts travel together. So it is a fronto-pontocerebellar pathway. The middle cerebellar peduncle, there are two peculiarities. One is it is not having any afferents. It is having only one efferent, and that efferent is the cortico-pontocerebellar pathway. That is one peculiarity. Second, that is the only area where the corticospinal tract is also traveling. So it produces a spastic ataxia. So ataxia with spasticity, ataxic hemiparesis. I call it as ataxic hemiparesis. So spasticity with ataxia is middle cerebellar peduncle. So normally, you know, cerebellum will be ipsilateral and the corticospinal will be contralateral. So this is the only area where there is spasticity and ataxia coexist. There are no eye signs, no dysarthria, no finger-nose incoordination. It is only a spastic ataxic gait. Then what about a superior cerebellar peduncle?
Mainly major afferents are anterior spino-cerebellar, ma'am, and tectocerebellar fibers will be there, ma'am. And it is a major afferent.
Which one, ma'am?
It is a major afferent peduncle of the cerebellum, ma'am. It contains most of the afferent fibers, including dentatobothalamic and dentatothalamic and.
So most important thing which produces symptoms in the superior cerebellar peduncle is olivodentato-robothalamo-cortical pathway. That is the most symptomatic. Others are tectocerebellar or cuneo-cerebellar or and you have got the vestibular-cerebellar, reticulocerebellar, and pondocerebellar. So many fibers are traveling, but the most symptomatic structure is the olivo-dentato-rubro-thalamo-cortical pathway. That pathway is otherwise called as tremor loop. So it contains the fibers which are mainly involving the upper limb, unlike the inferior cerebellar peduncle and middle cerebellar peduncle, which are concerned with the lower limb balance. Superior cerebellar peduncle is concerned with the upper limb balance, and the most functional tract is the olivo-dentato-rubro-thalamo-cortical pathway, and that is otherwise called as the tremor loop. So what will be the features of that when it is involved? Gait will be least involved. Among the peduncles, which can produce gait is the inferior cerebellar peduncle and the middle cerebellar peduncle. Superior cerebellar peduncle does not produce much gait ataxia, but occasionally it will produce gait ataxia because of two reasons. Would you like to tell what reasons, ma'am?
Overflow.
Yes, it is overflow. So it will be upper limbs will be maximum affected and mild imbalance in the lower limb. Then there is something called uncinate fasciculus of Russell.
Yes, ma'am.
That ascends from the lower brainstem and hooks around the superior cerebellar peduncle as it exits the midbrain and comes down without any relay. That is mainly concerned with the gait ataxia. So supposing you have got a plaque like a multiple sclerosis plaque at the exit zone of the superior cerebellar peduncle, where the uncinate bundle of Russell is hooking, then you may have lower limb involvement also in a fairly severe degree.
Okay.
Then would you like to tell the features of superior cerebellar peduncle involvement, ma'am?
Mainly it will produce appendicular incoordination, ma'am. Patient will have difficulty in performing fine movements in distal extremities, like in which involve movements of the fingers and at the wrist joint.
Yes, because it is olivo-dentato-rubro-thalamo-cortical. So you can remember like that. Okay, olive is different. Olivary nucleus involvement produces palatal tremor. It is part of the Gillian-Mollares triangle. Gillian-Mollares triangle is formed by the dentate nucleus of the opposite side, olivary nucleus and red nucleus of the same side. So because the olivo-dentato-rubro-thalamo-cortical tract is there, olivary nucleus involved means you get a palatal tremor. So that is little away from the superior cerebellar peduncle, but it's the same tract that passes through. Then you come to the dentate nucleus. Dentate nucleus will produce the classical intention tremor. So it's a proximal tremor of the upper limb, where the limb will go heavy when it is moving in a way in which it has to reach a target, but it will not be a terminal clumsiness. It will be the whole limb that moves forward and backward. That is dentate nucleus. Then in between the dentate nucleus and the red nucleus, you have got the main stem of the superior cerebellar peduncle. Typically, main stem of the superior cerebellar peduncle gets involved in multiple sclerosis, then Wilson's disease, then you have got the fragile leg syndromes. So in these conditions, you get the wing beating tremor. So dentate nucleus is intention tremor, and in between the red nucleus and the dentate nucleus, you get the wing beating type of tremor, and then you reach the red nucleus, you get the horizontal action tremor. That is otherwise called rubral tremor. It is produced by action, and the classical typical one is horizontal, but the common one is not horizontal. So a specific one is horizontal action tremor, but commonly it is not the horizontal thing, it is up and down only. But to be 100% specific, it is horizontal action tremor. That is red nucleus. Then you go to the thalamus. Ventral intermedial arterial nucleus thalamus is called tremorogenic nucleus. So when this pathway reaches the thalamus, you get the essential kind of tremor. And when it reaches the motor cortex, there is a balance between the command loop and the correcting loop. So it will be a dysmetric tremor. But if you are asked superior cerebellar peduncle, you will say if it is close to the dentate nucleus, it will be intention tremor. In between the dentate nucleus and red nucleus, it is wing beating tremor. At the level of the red nucleus, it is horizontal action tremor. And when it exits towards the thalamus, it is essential kind of tremor. upper limb dominant, lower limb does not get involved, asymmetrical, and ataxia is a gait ataxia is either overflow ataxia or it is due to uncinate fasciculus Russell. So in this patient, he is coming with a gross ataxia with wide base, and at that point of time, he is not having anything else. It is bilateral, it's not unilateral.
Yes.
So peduncles are less likely because usually peduncle lesions are unilateral. Common lesions being demyelination, inflammation, then you can get it in JC virus infection. So those things are all PML where the JC virus picks up the peduncles, and sometimes you get in fragile X. So they are all not expected to produce a bilateral ataxia. It is not spastic ataxia. And apparently at that point of time, we are not having any eye signs from the history. And it is so either you put it in the anterior lobe of the cerebellum, cat titubation is not there at that point of time. So peduncles are less likely because it is bilateral. And second, one thing which never happens with the peduncle is dysarthria does not happen. And the classical cerebellar type of nystagmus also does not happen. What kind of nystagmus you get is the vestibular type of nystagmus in inferior cerebellar peduncle. So peduncles straight away will think less likely because it is bilateral. Only gait ataxia, it can be Paleocerebellum, and flocculonodular lobe generally produces nystagmus and vestibular symptoms like reeling. Those things are probably not very obvious at this point of time. It is not the truncal ataxia. So probably from the history, we can localize it to the anterior part of the cerebellum. Possible. That becomes the most closest cause. Second, you told about sensory ataxia.
Yes,
So what are all the features of sensory ataxia, ma'am?
Patient will be having difficulty in performing movements, ma'am, which significantly improve with visual fixation on that activity, ma'am.
Yes, so that happened in this patient later.
Yes, ma'am.
Later in the course. Second, what is the other features, ma'am? So sensory ataxia is mostly subjective. It will not be the classical side-to-side swaying unless it is associated with the cerebellar component. If the cerebellar component is not there, sensory ataxia is because patient is not getting a thing called positive cortical tropism. You might have heard of the term called positive cortical tropism. What is that? When we are keeping our body part in a particular position for whatever purpose, based on the commands received to write or to dance or to whatever, that's an efferent command. But the brain is continuously informed, this is the position in which my body part is. That is called efferent copy signal. So the afferent command has come, keep your hand like this to write. And the efferent command goes back and tells, I have kept it in the way you want. So the brain will take agency of that body part. And brain will know this particular body part is carrying out what I am telling. So that is called a positive cortical tropism. Like your principal is telling you to do something, you have done it, and you have informed him you have done it. So there is a proper understanding. Here what is happening, the efferent command has come up, but afferent command is not going because of the sensory deprivation. So patient is very much frightened. He does not know, the brain will not take ownership for that body part because it is not getting efferent information. So at every step, he does not know where his body is placed. So it will be more subjective, very bizarre, and patient will put his feet in odd positions. At every point, he has to look at the feet, or if he is not looking at it, he will put it in bizarre postures. It is not the classical side-to-side swaying. It is bizarre posture. So sensory ataxia worsens in the dark. It is more subjective than objective. It is bizarre, and typically the sensory ataxic gait is called as stick and the stamp gait. So it is called stick and the stamp gait because patient will lift the foot too much beyond the area to which he should lift the foot, and then he will not know where he has to put it down. So he will bring down the foot with the thumb. So the thumping sound will be heard. And after some time, the patient will understand that he is unable to judge the distance or unable to judge the depth of the floor. So what he will do is, he will generally carry a stick, typically seen in tabes dorsalis. Patients with posterior column dysfunction, they carry a stick to know how much is the depth in which the next step is there. So they strike the floor with a stick. That produces the sound of the stick. But the moment, then they will know, okay, only this 5 inches, the next step is 5 inches below. But the moment the stick is removed, the patient loses the understanding of the depth. So he will still lift the foot too much and bring it down with a thud. So you alternatively hear the sound of the stick and the thud of the foot. So it is called a stick and the stamp gait. So sensory ataxia is worsening when the vision is removed, and there is a betterment when they are fixing their foot on the floor. It is more subjective than objective. It is bizarre and not the classical side-to-side reeling, and they have got the stick and the stamp type of gait over a period of time. So that is a sensory. So, but it will not be the broad base with side-to-side swaying. So your patient definitely has got a cerebellar component, and which is later followed by a sensory component. So that is what the gait of this patient is. And you told that this boy was very small, 10 years old at that time. And as you typically told, any small child getting an ataxia of new onset, you should typically ask about treatable ataxias which happened at that age group. So you should, you have asked it, you told whether there is any fluctuation or episodic deterioration. So, or any encephalopathy, all those histories you told. What is the thing that was in your mind, ma? 10-year-old child, you asked whether there is any fluctuation and all you told me in the history. Yes, why did you say that? What was in your mind? So now our patient's gait is mainly cerebellar to start with. This is followed by sensory. So it's a combination of sensory and cerebellar. Cerebellar onset and sensory later. That is the gait. You told that it is not showing fluctuation. Yes, that you told in the history. Yes, what was in your mind? 10-year-old child, definitely you should ask. And what was in your mind for the benefit of everyone, you can tell me.
Certain ataxias like episodic ataxias, they will have episodes of ataxia which relieve by some medications, ma'am.
Very good. So, any child with a symptom which is disabling like this, we should use all our energy to help the patient whether treatment is possible. So one, as you said, the channelopathies, the episodic ataxias, there are about 6 of them, and they have got some treatment options. So whether it is a classical episodic ataxia, so it will usually aggravate with fatigue, with fever, or any metabolically demanding situation, sleep deprivation, starvation, or even spontaneous fluctuation, then you may be able to treat the patient with the channel normalizing agents. So whether it is one of the episodic ataxia you wanted to know, so you ask for that symptom. Very good. Anything else where you get fluctuations like this?
Episodes of multiple sclerosis, ma'am.
Yes, it can be, but it usually not always ataxia. It will be disseminated in time and space. So childhood MS, you can look for remission and relapses. Agreed. 3, you have get intermittent ataxia in patients with the unstable craniovertebral junctions. So atlantoaxial dislocations are not always progressive compression and Arnold-Chiari malformation. In the early stages, it is episodic. So other conditions which may have treatment option and you may miss it if you are not very shrewd, that is the craniovertebral junction anomalies. Any other conditions, you have got metabolic ataxias.
Hypothyroidism.
Yes, hypothyroidism generally, it is not episodic. It can present with ataxia, I agree. Mostly in the adults, it presents with the ataxia. In children, what is the manifestation of hypothyroidism?
Cretinism.
It can present with mental retardation, agreed. It can present with the muscle weakness. Yes. Especially one is, as you said, typically mental subnormality, growth retardation, mental retardation, Then muscle weakness. What is the typical feature of hypothyroid muscle disease? Paraspinal muscles. No? So we call it as hypertrophy of the paraspinal muscle. Very few conditions produce this. So it is called Cocker-Deber-Semmeling. It's called Cocker-Deber-Semmeling. So you have to look at the paraspinal muscles. They are hypertrophic. So hypertrophy of the paraspinal muscles in children and calf muscles in adults. Calf muscle, we call it as Hoffman's syndrome, and paraspinal muscle, we call it as Cocker-Deber-Semmeling. Anything else? So mental retardation, growth retardation, Cocker-Deber-Semmeling. Third is precocious puberty. This is one of the easily treatable precocious puberty. If you cannot easily treat a pineal body tumor, you cannot easily treat a diencephalic syndrome, or you cannot easily treat a suprarenal tumor. But hypothyroidism can present with precocious puberty, that is called as von Wick syndrome. VONWYK, von Wick syndrome. That is because when there is hypothyroidism, there is a neuronal error at the level of hypothalamo-pituitary adrenal axis. So when there is hypothyroidism, hypothalamo-pituitary adrenal axis should produce more of TSH. But because of the diffuse slowing, there is a neuronal error, not always. If it happens, then instead of producing TSH, it will produce FSH and LH. So child gets precocious puberty. Treatment is very, very simple. Just correct the hypothyroidism. So that is the manifestation, whereas ataxia is more common in young adults and older individuals. So the hypothyroidism, and definitely it is not episodic ataxia. The episodic ataxia, CVG anomaly. Then you have got metabolic disorders, which present with episodic ataxia.
Urea cycle disorders, amino acidopathies.
Yes. So Hartnup disease, yes. Urea cycle disorder, mitochondrial, that is pyruvate decarboxylase deficiency, and intermittent branch chain aminoaciduria. These are the 4 aminoaciduria which present with classical as ataxia. Hartnup, which will have the pellagra like rash. So when the child presents with high protein diet ataxia, low protein diet no ataxia, then you think of a metabolic ataxia and you look for a pellagra like rash. It is there means it is Hartnup. Then urea cycle disorder, they will have the peculiar mousy odor in their breath due to the ammonia. And next, and they are drowsy. That also is worsened by protein-rich diet, and otherwise it is called refeeding ataxias. We are supposing the child is living with a modest amount of diet with very less protein, the child is all right. Supposing you have got a febrile illness and you lose weight, the family members will feed the child becomes ataxia. So it is called refeeding ataxia. Then pyruvate decarboxylase is a mitochondrial disease, a leash disease. It's called leash disease. Child will be sleepy, they will have stridor, they can have narcolepsy like attacks, and the lactate and ammonia will be higher. Lactate pyruvate ratio will be abnormal. That is mitochondrial leash disease. Then you have got the intermittent branch chain aminoaciduria. So these are the various aminoaciduria which present with the ataxia. And then some interesting condition is there in a small child, little more younger, that is called as Auto-brewery syndrome. That I am telling for the sake of interest only, because we may never see a case like that. Auto-brewery syndrome is self-alcohol syndrome. So what is Auto-brewery syndrome? Is a congenital immune deficiency. You know that we have got about 5 types of congenital immune deficiency syndromes, humoral and cellular combined, and immune deficiency with migration, macrophage migration defect, all those things. Among them, you have got the condition with the cell-mediated immune defect. By birth, cell-mediated immune defect is there. So what happens? Cell-mediated immunity is important for protection against fungal infections. So these children develop candidial infection of the GI tract. So they will have candida. So whenever you put carbohydrate food into the stomach, the candida acts on the carbohydrate and produces alcohol. and that alcohol gets absorbed. Child will have alcohol in the blood, and they will have classical alcoholic ataxia, which is precipitated by carbohydrate meal. So that is called auto-brewery syndrome. They do not survive because of severe systemic infections. They die before their first decade. So that is auto-brewery syndrome. So intermittent ataxia is relevant in a child, and we want to look for treatable causes. So that is very correct, but it is not intermittent, it is steadily progressive.
Yes.
Next, you told, so there is involvement of cerebellum, there is involvement of sensory, both contributing to the gait impairment. Then he noticed difficulty in involvement incidence, okay. And you told that he had occasional falls. No?
Yes. Yes.
So how did he fall?
Initially used to fall during running or doing any during walking, ma'am, when only it was cerebellar type, ma'am. Later frequency of falls increased, ma'am, when sensory component overlapped with the initial ataxia, ma'am. Then he has more falls during night and while washing his face. Falls were more, ma'am, and during the fall patient was conscious, ma'am, and he used to take support of his hands while falling, and he used to get up immediately after falls, ma'am. He has not sustained any serious injuries, ma'am.
Oh, so we have considered many conditions. So here you have clearly told that he is falling more in the night when the light is removed. Yes. So it is something like a wash basin sign which is making the child fall. When two components are removed, one is the cerebellum is less functioning, sensory is less functioning, and the visual component, which is the only one which is helping the child, is also removed. The child falls. So it is understandable. It looks like a wash basin effect. Because combined involvement of cerebellum and proprioception, child is left with very minimal rescue reactions, and that is also removed, means he falls. As you clearly told, any fall you should tell with consciousness or without loss of consciousness, and without loss of consciousness, vertiginous or non-vertiginous, and without vertigo. In this child, we thought about whether he is having a CVJ anomaly. So I have seen CVJ anomaly patients being treated as seizures because they can have intermittent dislocation of the odontoid and compressing on the high cervical cord structures, and the person will buckle. So if you don't clearly ask whether he had any loss of consciousness, all those things are not there, repeatedly falling and getting up. I have seen the patients being treated as seizures because of inadequate history taking only. So CVJ anomaly, people can have buckling and falling. Then you can have cataplexy attacks. No? So without vertigo can be high cervical cord compression itself, or it can be cataplexy attacks, or you can have drop attacks. When there is CVJ anomaly, because the vertebrobasilar system becomes compromised, you can have drop attacks due to vertebrobasilar ischemia. So now, then whether it is there buckling and falling, it's a spastic. So they have a stiff buckling and they can fall, or reeling and falling, swaying and falling, falling forward, falling backward. And the anterior-posterior axis, it is usually extrapyramidal disorders. So anterior-posterior axis is extrapyramidal, side to side is cerebellar, and wash basin effect is sensory. Then if they have falls with buckling, it is a stiff buckling. Multi-directional, without warning, sudden falls and getting up, you get it in diseases which involve the pedunculopontine oscillator complex, which is the pacemaker for motor activity. That typically happens in adults with PSP syndrome. So that is there, they fall like that. And you should never forget the Stoke-Adam attacks. And you can chromaffin tissue tumors, whether there is sudden palpitation, sweating, flushing, and they fall. There may be an organ of sugar candle tumor somewhere in the bifurcation of the aorta, suprarenal, or in the glomus jugulare region, intermittently releasing biogenic amines. Those things are very difficult if you do not ask the classical history of flushing and palpitation and falls. So these things they can present with falls. Not in this case, it is very clear it is a wash basin fall, but all those histories are important to pick up rare causes for frequent falls in a child. So this child seems to have cerebellum, not the peduncles, and the child seems to have sensory ataxia, and he used to feel the presence of slippers. Okay. Patient difficulty in approximating slippers with gripping. So what was the problem while he was walking? Chapel, what is the problem with holding on to chapels?
If he doesn't look at the slippers, he has difficulty in wearing and both gripping, ma'am. But if he looks at it, he can wear it easily. He can negotiate both easily, and then gripping is also better, ma'am, if he keeps his eyes on his.
So the motor component is not contributing to the gripping. It is a sensory component. So we tell if the child can hold on and walk and put it on easily and remove easily, provided his gaze is on the feet. Gaze is on the feet, putting in is easy, holding on is easy, removing is easy. That is sensory.
Yes.
So that is what you are telling. So this looks like a sensory component. If it is motor component, child will have difficulty in holding on and walking. If it is upper motor neuron, all three components will be affected. So in this child, it is a sensory component contributing to the slipping of chapels. Then he is not a, okay. So at this point, you said that he developed some dysarthria later. Is it so?
Yes, ma'am. Later.
What was the type of dysarthria?
Patient has
splits the syllables. No?
Yes, ma'am.
So for the sake of all your colleagues who are younger than you in the first year or in the final MBBS, would you like to tell me what is the definition of dysarthria and what are all the types of dysarthria?
Dysarthria is mainly it is the speech problem, ma'am. Any difficulty in articulation of sound, it is called as dysarthria, ma'am.
So classically, if you want to define, you will call it as ability of the individual to convert language into audible sounds.
Yes.
Because language is already there and dysarthria does not involve all the components of communication.
Yes.
It is only the spoken component. So ability of the individual to convert language. So language is there, but you are unable to convert it into audible sounds. Other components are all right. Comprehension is all right. Reading is all right. Writing is all right. Then it is dysarthria. So that is what this child is having. And what are all the types of dysarthria?
Spastic dysarthria, flaccid dysarthria, and ataxic dysarthria.
Spastic, flaccid, ataxic, dyskinetic, and cortical. So these are the types: spastic, flaccid, ataxic, dyskinetic, and cortical. You said that he is splitting the syllables, then it typically fits into staccato kind of ataxia. What will be the typical feature of scanning kind of ataxia? Which will when will you call it a staccato?
If it is there is a sudden increase in the amplitude of sounds,
so you call it a sudden explosiveness.
Yes, yes.
So sudden increase in the pitch, which gives an explosive character to the communication. Then you call it as a staccato. When the syllables are split, you call it a scanning. Apparently, your patient seems to have scanning speech. That means probably some extension to the neurocerebellum is happening. You know the three monkey homunculus in the cerebellum, which I have told in the previous classes. You know, no? In the cerebellum, there is a three monkey homunculus. The human body is represented in the cerebellum as three monkeys. Based on that, only the signs are coming. In the Vermis, the trunk of all the side-lying monkeys and the head and neck of the monkey which goes towards the Paleocerebellum is there. All the upper limbs, head and neck and eyes are in the Neocerebellum. The trunk of all is in the Vermis and the head of the monkey which goes towards the Paleocerebellum is in the Vermis. That is why you get titubation and truncal ataxia in the Vermis. Eye signs, speech and upper limb in the Neocerebellum. Leg of the single monkey which lies supine with the head in the anterior Vermis, upper limb going to the Neocerebellum and lower limb to the Paleocerebellum. And the lower limbs of the side-lying monkeys in the flocculonodular lobe. So you have got three monkeys like this. Vermis, two monkeys, the head and neck is going there, upper limb is going there, and leg is in the flocculonodular lobe. The other monkey, which is lying supine, the head and neck is in the anterior vermis going to the neocerebellum, upper limb goes to neocerebellum, lower limb goes to the paleocerebellum. That is why gait ataxia in paleocerebellum, upper limb incoordination and speech and eye signs in the neocerebellum, and lower limb ataxia in the flocculonodular lobe. So some degree of dysarthria is happening means there is some degree of extension of dysfunction to the neocerebellum. What about upper limbs? He said that there is some clumsiness in the upper limb.
Yes.
He is unable to hold the pen.
Yes.
So what does it, does he drop the pen? So when you hold the pen and write, you can have tremors. So tremor can interfere with that. Or you can have difficulty in gripping due to weakness. Or you may have something like a writer's cramp. So you should ask all these things. Is the limb going into some abnormal posture? Or is he manifesting tremors while writing? Or does he have any weakness and unable to give the proper power to the pen while he is writing? That if you get only, we will know what exactly is happening. Is it the tremor which is interfering? Or is it any other component, extrapyramidal component is there, like writer's cramp? Or there is weakness resulting in decreased power? That component we will know only when we analyze it better. And he told that he was good in the subject, but he failed.
Yeah, he was not able to write the answers, ma'am. He was knowing, but his handwriting slowed down significantly that he was unable to write all the answers. He was doing.
Okay, that was his explanation. It is possible that he did not have the proper coordination with the upper limbs, and so he could not finish the exam in time. That is possible. And he claims that his cognition was very good. Yes. But can cerebellum affect cognition?
Yes, ma'am.
Yes. So yes.
Pontocerebellar fibers will be there, ma'am. They also have a role in cognition, ma'am. Patient might have.
So what are all the cognitive manifestations you can get in cerebellar disease?
Visuospatial loss might be there, ma'am. And language problem might also be there, ma'am.
Yes.
And
so what is told is, in the same way that cerebellum affects the rate, range, rhythm, direction, and amplitude of motor activities, cerebellum affects the rate, range, rhythm, and a pattern of cognitive activity. So you will be slow, you will be erratic. No? So it is affecting the rate, range, and rhythm of cognitive function. So what is classified is cerebellar cognitive affective syndrome. That's the type 1. So they are slow. They take longer time. And over a period of time, they may give fragmented answers. So you ask complete address. They may tell the name of the house and stuff. So they take more time. That is cerebellar cognitive affective syndrome. It will look as if they are depressed and they do not want to communicate. Because it is part of the procedural memory, executive function, circuit, everything is involved. So they are slow. They appear as if they are not wanting to cooperate. They give partial answers and they give fragmented answers. That is called cerebellar cognitive affective syndrome. That is type 1. Second, as you said, apathy and aphasia. So they are that is second group of disorders. They are apathetic and aphasic. And language in the cerebellum, unlike in the hemisphere, which is in the left side, in the cerebellum, it is in the right side and in the flocculonodular region. So right flocculonodular region is concerned with language. So they can have language abnormality, not just the staccato and the scanning type of speech. So that is called apathy aphasia syndrome. Third is the cerebellar mutism. And cerebellum and music. These are the 4 categorization: cerebellar cognitive affective syndrome, aphasia apathy syndrome, cerebellar mutism, and cerebellum and music. So what happens in cerebellar mutism? It typically happens in the neurosurgeon's table when they operate on a medulloblastoma. Pre-operatively, child was talking, and after the surgery, child stops talking. That is because cerebellar midline cerebellar structures are linked to the subcortical language area. That is called Mary's quadrilateral space. That's the area which covers the anterior lip of the corpus callosum to the anterior lip of the insula, posterior lip of the genu to the posterior lip of the insula. There you have got external capsule, internal capsule, caudate, thalamus, globus pallidus, and putamen. So all these structures form the motor schema for language. So cerebellum is linked to the subcortical language area of the Mary's quadrilateral space. So temporarily, when the tumor is removed and hemodynamic changes take place in the cerebellum, there is locking down of the motor programming. So that results in cerebellar mutism. Fourth is the cerebellum and music. As we say, rate, as I told, that rate, range, rhythm, direction, and amplitude of cognitive function. So as you know that music has got a ragam, thalam, and pallavi, it is told. So pallavi part is okay. Ragam part gets affected due to scanning and staccato component, and the thalam part gets affected due to the timing defect. It's the rate. So thalam will be affected, ragam will be affected, pallavi will not be affected. That is cerebellum and music. So cognitive syndromes of cerebellum are classified into 4: cerebellar cognitive affective syndrome, apathy aphasia syndrome, cerebellar mutism, then cerebellum and music. No? So he could have not slow down motor function. He could have slowed down in the cognitive function also. It will be very subtle compared to the ataxia, which will be staring at us. So it can be missed, and you may give excuses. Small child is so disabled. Why you will trouble him asking cognitive questions? But in fact, his cognition might also be slowed down. We don't know. So that we will have to examine, then only we will know. So that was his exam performance. Then what happened, ma'am? Then you notice increased curvature of the foot, you told.
Yes, yes.
What is that? What is that, ma'am? What situation you get increased curvature? In what position you correctly measure the foot curvature? What is the bedside? At the bedside, how will you examine? Look for the curvature of the foot at the bedside.
No.
Ideal way to pick up Pescavus is to make the person sit and hang the foot loose. When the foot is loosely hanging, then you will see the arch very well. Then, as you said, you can make a wet feet on the floor and see the impressions, how much of the anterior posterior part and the lateral part is producing an impression. It will be very less. The outer margin will be producing more impression, and the inner border will have very less impression. That is a second bedside point. Then you have got the subtalar angle measurement. You can measure the angle through the talus, anteriorly and posteriorly. So how much angle is sustained, then you will know whether there is a Pescavus. So apparently it looks like a Pescavus which is observed by the patient himself.
Yes.
Then what else, ma'am? That's all?
Ma'am, these 4 is the chief complaints, ma'am.
Okay. Then now tell me the structures that are involved in your child.
Considering
yes, cerebellum and plus minus
Spino-cerebellar.
So how will you know whether it is a bony type of Pescavus or is it due to peripheral neuropathy or motor involvement? So if you are able to change the deformity, when the child puts the feet on the floor, if the Pescavus corrects itself, that is due to lack of support system to the bones involved in the arches of the foot. No? Like it may be due to the peripheral neuropathy with some motor involvement, or it can be due to the muscles that are supporting. So if they are causing the Pescavus part where the arches are damaged, then it will be a correctable type of Pescavus. If it is due to bony deformity, when you examine the patient, you will understand that you are not able to correct it. So you want to know whether the Pescavus is neuromuscular or bony, and that you will examine and see whether it is correctable or not. So the structures involved: posterior column. Second structure involved is cerebellum. Third structure involved is probably bones. Yes. And probably we don't know whether he's having a peripheral motor involvement, that you are not clear. So clearly it is posterior column is involved. And clearly cerebellum is involved, and bony deformity is there. in a young child or a progressive disease. So as I always tell, any disease progressive, we thought about all the episodic conditions. Progressive conditions are 3: degenerations, tumors, slow viruses.
Yes.
So anything progressing over years, it can be degeneration, it can be slow virus, it can be tumors. So tumors like cerebellopontine angle tumor, bilateral, but it will produce other features, deafness will be there, and ICP features will come, other features of tumors you should think of. Progressive means 3. That is for people to remember. Is it a tumor? Is it a slow virus? Or is it a degeneration? Degeneration last because we can do little to the patient. So when it is a progressive thing, you always look for all these things and you ask for features. If it is medulloblastoma child, no, not he will not grow up to this age with a medulloblastoma. It is growing. Cerebellopontine angle tumors are very slow growing tumors, but they do not produce posterior column. He has ataxia, but you will get primary type 2 neurofibromatosis. There you get only the cranial nerve features and cerebellum, not the posterior column. So bilateral auditory neurofibroma, less likely. Medulloblastoma, totally not likely because child going on for so many years. So it is not at all possible. So tumors are not possible. Slow viruses producing ataxia. You know some slow virus producing ataxia, ma?
JC virus.
EPIGNOSIS. So if the child is having a childhood HIV disease or some other immune compromised disease, it can be JC virus, but again it will not produce posterior column ataxia. It will produce a middle cerebellar peduncle. Then child will not go on for so many years. So it is usually involving signal changes in the peduncles, white matter, large non-enhancing lesions, radiologically, clinically asymmetrical, and after that the child won't live so many years. So totally unlikely posterior column does not get involved. Second cause of slow virus disease will be prion disease, Justman-Straussler, severe myoclonus with ataxia. They also will not go on like this, so very unlikely. So you land upon degeneration. So most likely by excluding all the progressive condition, it looks like a degenerative conditions. So degenerative ataxia, I always tell this, you have got modified Greenfield's classification. It's an outdated classification. Now the classification that we use in ataxia is the genetic classification. But for the bedside, modified Greenfield's classification is very, very useful. So you'll get an idea. This case may be straightforward, but you may meet a case where you are not able to fix your anatomy. There, if you use the modified Greenfield's classification, it's a very old classification. It is very, very useful. So modified Greenfield's classification classifies ataxia into purely spinal. Second is spino-cerebellar. Third is brainstem cerebellar. Fourth is cerebellar cortical. So that is modified Greenfield's classification. Very useful for bedside categorization. Purely spinal means only spinal cord features will be very dominant. So they will have spasticity. They will have ataxia. And the ataxia may be sensory, or the ataxia can be due to Clark's column degeneration. They can even have side-to-side swaying because of involvement of the spino-cerebellar tracts. So when the spino-cerebellar tracts degenerate, it is always in the company of spasticity with or without posterior column. And the ataxia is very subtle. It will be only gait ataxia, no other component, no intention from her, no speech, nothing. So purely spinal will have predominant spinal cord features like spasticity, posterior column, plus subtle ataxia due to Clark's column involvement. That is Greenfield's purely spinal. So this will not fit into the purely spinal because he started with a cerebellar type of ataxia, broad base, side-to-side swaying. So this is not the purely spinal of Greenfield's. Second is the spino-cerebellar. That means you have got some features which you cannot put it into the intracranial compartment. You have to take the posterior spinal cord. So in this child, the posterior column. Posterior column, you cannot put it into the intracranial compartment. He definitely has got a posterior column involvement. That
Ma'am,
means
one doubt, ma'am.
which one, ma'am?
This patient is having sensory ataxia, ma'am.
That's what.
Lesion can be in proprioceptive sensory fibers or in posterior column, ma'am.
Yes.
History basis, how can we differentiate, ma'am, whether it is lower?
That is what history wise.
Is it
Large
posterior
fiber neuropathy. Large fiber neuropathy is what you are meaning.
Yes,
then you will have symptoms which are in the Glavan-Stocking distribution.
Okay.
So patient will tell that my sensory features are in the they may say that they have got symptoms. History wise, it will be a Glavan-Stocking pattern that will help us. If that is not there, you are not able to call it as a Glavan-Stocking. Posterior column and peripheral nerve can be examined and differentiated very well. When you are examining, length dependent pattern is peripheral nerve. So when you reach the knee joint, the upper limb reaches the tip of the toes. That is length dependent pattern. Proprioceptive symptoms are reaching the knee in the lower limb and tip of the fingers in the upper limb. Second, reflexes are absent. When it is proprioceptive peripheral nerve fiber that is getting involved, reflexes will be absent. And generally, joint position, movement and vibration, everything get uniformly involved. Whereas in posterior column, it will not be Glavan-Stocking. It is not length dependent. It will have bizarre pattern. So when you examine, you might find that proprioceptive dysfunction is up to the angle in one side and up to the hip on the other side. Third, there can be dissociation between position, movement and vibration because they are having a lamination. Ventrodorsal lamination. Vibration is ventral, movement is middle, and position is proximal. So they can be differentially involved when there is a partial degeneration of the posterior column. And reflexes will be preserved. So posterior column after examination, it is bizarre, not length dependent, and it can have dissociation between vibration, movement and position, and reflexes are retained. Whereas peripheral nerve, all phenomena get involved, vibration, movement, position, they show a length dependent pattern and reflexes are absent. So that is clinically. History wise, if the person gives a Glavan-Stocking type of some sensory symptom like tingling or something like that, then you can call it as a peripheral nerve. Anyway, it is not in the intracranial compartment. So sensory ataxia of this patient is not in the intracranial compartment. He definitely has got a cerebellar ataxia and cerebellar ataxia with a sensory ataxia which is extracranial, either in the spinal cord or in the peripheral nerve. So you can have ataxias with peripheral neuropathy. You get it in mitochondrial disorders, NARP and things like that. Or you can have posterior column ataxia and cerebellar involvement. So then you say spino-cerebellar. That means you have to take the spinal cord. If the posterior column is involved, you have to take the spinal cord. If the peripheral nerve is involved, it is a NARP-like syndromes, where is peripheral neuropathy with cerebellar signs and mitochondrial disorders. So either of them. So Glavan-Stocking history is not there. When you examine, you might find it. If it is not there, it will be column. So if the column is involved, you have to localize in the spinal cord. Column cannot be localized in the intracranial. So spinal cord plus cerebellum. That belongs to second category. So if you have other features of spinal cord, spasticity or posterior column or some bladder features plus intracranial, then it is spino-cerebellar. Under spino-cerebellar in modified Greenfield's classification, you have got Friedreich's type and non-Friedreich's type. So purely spinal is hereditary spastic paraplegias, hereditary spastic ataxias, tropical spastic paraplegias. They are the class purely spinal. Then the spino-cerebellar, if it is in the spinal cord and not in the peripheral nerve, it is you have got the Friedreich's type and non-Friedreich's type. Friedreich's, you know, early onset, areflexic, absent, HFS, cavus, bony involvement, all those things are there. Friedreich's. Hyperreflexic, Charlevoix-Sigani syndrome, spastic, the type of spinal cord involvement, they are the non-Friedreich's type. So is it a spinal cord definitely involvement, Friedreich's and non-Friedreich's. Then you go to the brainstem cerebellar. The brainstem cerebellar, how do you? Lower cranial palsy, or you have got eye signs or red nucleus. Under that, you got olivo-pontocerebellar, olivo-rubrocerebellar, which comes under the SCA, late onset SCS. The current genetic classification comes on the late onset SCA. That is brainstem cerebellar, lower crenular involvement, red nucleus involvement, eye signs, and cerebellar, no spinal cord features. Then fourth is the cerebellar cortical, where there is a pure ataxia. Mary's late onset, Mary's type of cerebellar ataxia, paraneoplastic ataxia, they are all the purely cortical. So that is cerebellar cortical. So if you apply this modified Greenfield's classification,
Yes.
you can put it as something which is not purely spinal, not brainstem cerebellar, not cerebellar cortical, but spino-cerebellar. So whether it is a Friedreich's or non-Friedreich's, because you have got spinal cord as by posterior column, and you have got cerebellum definitely involved because you are having dysarthria, finger nose incoordination, all those things, plus minus some systemic involvement like a bony involvement is there, we don't know. So this modified Greenfield's classification, I always felt that it should not be discarded for bedside neurology. It is very, very useful. Autosomal recessive cerebellar ataxia, but it is not purely cerebellar, as you clearly said. You are having posterior column involvement. You are probably having a skeletal involvement. So it is not purely a cerebellar ataxia. So it comes under spinal cord. You can have a Mendel categorization. It is a progressive disease. It is not fitting into the classical progressive ataxias of tumors or slow virus. So it is degeneration. And when you come to degenerative ataxia and apply the modified Greenfield's classification, it comes to a condition where spinal cord is involved, cerebellum is involved, plus minus bony involvement. So it is a spino-cerebellar. It is not a purely spinal. It is not the brainstem cerebellar, that is the late onset ataxias, and it is not the cerebellar cortical. It is not hereditary sensory neuropathy because it is clearly cerebellar.
Cerebellar to start with.
If you are having dysarthria, broad-based gait, incoordination, clumsiness, everything is there. And subacute combined degeneration of the cord, you will get spasticity, you will have posterior column, you will have dementia, but you do not get it with the cerebellar onset. So I don't think other DDs are important. At the end of history, you will say that my patient has following structures involved probably. That is posterior column, definitely cerebellum. It is not the Clark's column. You see, Clark's column ataxia in the spinal cord will be just ataxia. It will not have dysarthria. It will not have finger nose signs. All those things are there in your patient.
Yes.
So it cannot be a purely spinal cord producing a sensory ataxia plus Clark's column. So it is spinal cord plus cerebellum. So there is no doubt about that. So you will not put it as a pure ataxia of sensory or cerebellar nature. It is not all those different. So you'll say, but at the examination, I feel my patient has got posterior column involvement probably, which I will examine and see whether he is having a variant type of peripheral nerve producing sensory ataxia. In that case, I will consider the possibility of a mitochondrial neuropathies, which can be with the ataxia, that is NARP. Then you have got syndromes called CATCH, cerebral ataxia plus neuropathy. They are all mitochondrial conditions which are progressive. So CATCH syndrome, NARP syndrome. So whether it will fit into all of them. And I don't think I will consider subacute combined degeneration of the cord when there is a dysarthria, and if he is having dementia, I might consider, because they can have B12 deficiency related dementia.
Yes.
But so purely cerebellar with speech involvement, I don't think. You can say if you want to consider the proprioception as peripheral nerve,
Yes.
then you may put the next DD. First is the
Spino-cerebellar.
spino-cerebellar ataxia. Second, you can put variant ataxias like NARP or CATCH syndromes, where you can have involvement of both cerebellum and the spinal cord. That will become the differential diagnosis. Next one. On examination, you tell me.
General physical examination, patient is conscious, cooperative, well-oriented to time, place, and person. Patient's BMI is 29 kg per meter square. Ma'am. There is no pallor, icterus, clubbing, sinus, lymphadenopathy, or pedal
His
edema.
weight is 93 kg. Yeah?
Ha, ma'am.
In that case, BMI should be high, no?
29, ma'am, is BMI. Height was 177 centimeters, ma'am. His BMI was 29.
Okay.
Oral cavity hygiene is good, ma'am, and dental formula is normal. And on examination, pes cavus is present, ma'am. There is no any telangiectasias or no.
What is this 2123?
That is dental formula I have written.
What is that? I don't know. I want to learn.
2
2 means what?
incisors, ma'am.
Oh,
2
he's having 2
incisors
incisors.
and then 1 canine tooth is there, ma'am.
And 2 premolar and 3 molars. Huh?
3 molars, yes.
Okay, very good. I never knew that you can represent the dental formula in this way. Very good. I learned 1 point. Thank you very much. Next, tell me.
Tongue is normal, ma'am. And pes cavus is present, ma'am, in bilateral foot, ma'am. Left more than right, ma'am. And there is no telangiectasias or no neurocutaneous markers.
What other things you will describe in a patient general examination in an ataxic patient, whatever may be the ataxia? Do not forget to look for cataract. Yes. Do not forget to look for KF ring. No? Telangiectasia, you clearly told. Eye signs, then you can have aniridia, absence of iris. So cataract, KF ring, absence of iris, telangiectasia, pingucula. Pingucula you get in gotchas. They can also present with ataxia. So pingucula, cataract, KF ring, aniridia, and telangiectasia, you should mention. And eyes. And you told about BMI and all, too tall and too short you tell. You have 2 short people can have cranial junction anomaly. 2 tall people may be Klinefelter, things like that. They can present with ataxia.
Yes.
So height, then you will general exam eye signs, neurofibromatosis, then you are told the neurocutaneous markers. Then okay, go on. Hair will, what is the role of hair in ataxia? Not in this case.
Yes.
What all ways hair will help you?
If it is a metabolic cause of ataxia, ma'am, in
yes. What metabolic conditions you will produce hair alteration?
Menkes.
Yes, very good. Very good. But will you consider at all Menkes in this case?
No, ma'am. There is. It might be episodic, ma'am. If any metabolic cause, there will be episodic ataxia.
Not like that, ma'am. Menkes children don't live even up to 1 year. Okay. They will die. Okay. Menkes kinky hair syndrome. They die very early. You can never imagine. So hair, of course, I forget about this. You can say hair, hypopigmented brown, kinged hair, lanugo-like hair sticking onto the scalp. The ataxia will not be obvious. If they survey, you may be able to find out, but it's very less likely. Then you have got curled hair and sensory neuropathies. You have got hereditary neuropathies with the curled hairs is there. They will have sensory ataxia. Giant axonal neuropathy. Condition giant axonal neuropathy, where there will be very kinged type of hairs with peripheral neuropathy and sensory ataxia. Then you might find hypopigmented hair in ammonia disorder, that is organosuccinic aciduria. They have a hypopigmented hair. Tyrosinemia. So tyrosinemia, organosuccinic aciduria, there it can go with late onset, little ataxia and hair changes. Then what about the tongue you told?
Tongue is normal. There are no fasciculations.
Supposing amyloid neuropathies, no?
Yes.
If amyloid neuropathy, you might find a big tongue.
Yes.
Then teeth, lead neuropathies.
Yes.
And porphyrias, they are all peripheral nerve induced ataxias. Yes. So tongue, teeth, tonsil, we say you have got Trangius disease.
Trangius, yes.
So they will have peripheral neuropathy. So tongue, teeth, tonsil, skin, hair, nail. Skin, hair, nail, tongue, teeth, tonsil. Then eye, neurocutaneous, CV junction, height of the neck. So all those things you should mention, so that you, not in this case, generally keep it in your mind so that we do not miss any other case. Okay, next one.
Vitals are normal. Ma'am. Pulse rate was 78 per minute, regular, normal volume and character, no radioradial or radiofemoral delay. And condition of the vessel wall is normal and all peripheral pulses were felt well. And it was 124/80 measured in right arm supine position, and respiratory was 16 per minute and regular, and temperature is 98 degrees.
Okay.
Nervous system examination, ma'am. Mental functions, level of consciousness, he was conscious, oriented to time, place and person, and following commands, and his GCS was 15/15, ma'am.
Okay.
Mini mental status examination, his score was 28/30, ma'am.
Very good.
That 2 points, ma'am, mainly because of dysarthria, he was not able to repeat the complex sentence, ma'am, do, ifs and buts, and because of his incoordination, he was not able to draw that complex diagram, ma'am.
Okay.
Apart from that, his all that memory and everything is normal, ma'am. And insight and judgment is normal, ma'am. Abstract thinking is normal. Speech is slow, scanning with the abnormal prosody, and unintentional pauses were there, ma'am, pointing towards ataxic speech, ma'am. Language, normal comprehension, naming, repetition, reading and writing, ma'am. Memory, immediate, recent, remote, all were normal. Cranial nerve examination, all cranial nerves were normal. Olfactory nerve was normal, no abnormal taste, smell.
So can you tell one condition where you get ataxia with the olfactory nerve? Ruffson's disease, no? Phytonic acid abnormality, Ruffson disease. So it is very important. Why it is very important, ma'am?
It is also one of the causes of hereditary neuropathy.
It is treatable. You see, Ruffson's disease, phytonic acid.
Phytonic acid. Yes.
So you have got a special diet for Ruffson's disease, as well as when the phytonic acid levels go very high in the blood, the person becomes very ataxic. You can do plasmapheresis. So plasmapheresis will remove the phytonic acid. And dietary management will maintain after once you do the plasmapheresis, remove the high levels, you can maintain with the phytonic acid free diet. Okay.
Optic nerve is normal. Visual acuity, both distant and near vision was normal. Color vision was normal.
What is the role of vision, ma'am?
In usually ataxias, optic nerve can be involved, ma'am. In
Yes.
several
So you can have
ataxias.
optic atrophy,
Yes.
you can have RP, you can have colobomas, you can have telangiectasia in the retina, no?
Yes.
Weiband-Mason syndrome, von Hippel-Lindau syndrome, no?
Yes.
You can have telangiectasia in the retina.
Yes.
You can get coloboma in the retina and Gillis-Bush disease, where will be aniridia, coloboma in the retina. And you can have RP in mitochondrial disease. You get optic neuropathy in many types of spinocerebellar ataxias. Okay.
And visual fields were normal, ma'am, by confrontation method, and slit lamp examination was normal, ma'am. Fundus disc was normal, vessels were normal, and foveal reflex was seen.
Okay.
And, third, fourth, and sixth cranial nerves were normal, ma'am. Both eyes were normally aligned with normal extraocular movements in all directions. There was no
eye signs. Can you tell me what is the importance in ataxia?
patient.
Now in this early onset ataxia, the classical spinocerebellar ataxia 1, 2, 3. They are associated with eye signs. No? SCA 1, 2, and 3 are associated with eye signs. So that is very important. Short duration ataxias with eye signs, do not forget Miller-Fisher syndrome. Not in this case, generally. This is a very long duration progressive condition. So eye signs in the presence of ataxia, long duration will be SCA 1, 2, 3. Short duration will be Miller-Fisher syndrome. Next.
And trigeminal nerve is normal, man. Normal jaw movements and normal mouth opening and closing. Sensation
Any
of the
condition where you get trigeminal neuropathy and ataxia? Digerin-Sota.
Okay.
Digerin-Sota's disease, there is a sensory ataxia due to peripheral neuropathy and you have trigeminal neuropathy. Second, we call tilbamidine. Olden days, there is a disease called Kala-Azar, which is now almost not there. So that used to be treated with antimony compound. So antimonials produce trigeminal neuropathies, in addition to neuropathy-induced ataxias. Okay, next one.
Facial nerve was normal, normal facial expressions, no deviation of angle of mouth or drooping of eyelids or loss of nasolabial folds, normal wrinkling and eye closure and blowing through the mouth. Taste sensation were normal in anterior two-thirds of the tongue, and sensation of the tragus and external acoustic nerves normal. And vestibulo-ocular nerve was normal. René's was positive, Weber's no lateralization, and earbone conduction same as exam.
Okay.
And 9, 10, 11 examination was normal. There is no dysphagia, no
Some of the ACAs, they involve the Joseph Mercado group, no?
Yes.
They involve the lower canal nerve, tongue atrophy, no?
Yes.
So that is important. Okay.
And hypoglossal nerve is also normal. No obvious atrophy of tongue muscles, and there is no deviation, and there is no weakness or neither any fasciculations. Motor examination, posture and attitude, comfortable in all postures except in standing, ma'am. While lying down or while sitting, patient was not having any problems. And inspection, there was no wasting or fasciculations or atrophy, and muscle palpation was normal, ma'am. There was no tenderness, ma'am.
Okay.
Bulk was normal, ma'am, on either side. At thigh, it was 54 centimeters on either side. Leg, 35 centimeters on the right side and 35.5 on the left side, ma'am. Arm bilateral, it was 32 centimeters, and forearm, it was 28 centimeters. And tone, it is normal in both upper and lower limb. Power, ma'am, at all joints, the power was 5/5, ma'am. At shoulder joint, it was in all movements, flexion, extension, abduction, adduction, it was 5/5. At elbow joint, flexion and extension, it was 5/5, ma'am. And at wrist joint, all movements were 5/5, ma'am. And at finger also, power was normal, ma'am. Extension, flexion, thumb movements, and small muscles of hands. Power was, yes. In lower limbs also, ma'am, at hip joint, flexion, extension, adduction, abduction were 5/5, ma'am. And at knee joint also, flexion and extension was 5/5, ma'am. In ankle joint and toes also, power was 5/5, ma'am. Patient was having normal, no motor weakness, ma'am. And at neck flexion and extension is also normal, and spine flexion and extension is also normal.
Does he have any scoliosis? No.
No, ma'am.
Okay.
And then superficial reflex, ma'am. Abdominal reflex was present, ma'am. Plantar bilateral, it was extensor, ma'am. And anasteric reflex is present, ma'am. And deep tendon reflexes, there was generalized areflexia, ma'am. None of the reflexes were present. Triceps, brachioradialis, and patellar and ankle all were present. Sensor examination, ma'am. Pain and temperature, they were normal, ma'am. Below the ankle joint, he was telling me 80% of the pain sensation was reduced, ma'am. But there was no any gross abnormality in pain and temperature sensation, ma'am. And light touch, ma'am, it reduced touch sensations below the knee joint and normal in upper limbs, ma'am. Light touch, ma'am. And vibration, ma'am, in the lower limbs, it was reduced till anterior superior iliac spine in both the lower limbs, ma'am. And in the upper limb, it was reduced till the elbow joint, ma'am. And joint perception, ma'am, impaired in bilateral lower limbs till metatarsophalangeal joints, ma'am. At ankle joint, he was able to perceive, ma'am. And in upper limbs, till distal interphalangeal joints, ma'am. Proximal interphalangeal joint, he was able to appreciate.
Okay.
Vibration and proprioception, significant loss was there, ma'am. Pain and temperature were normal. Cortical sensation, ma'am, it cannot be tested on the lower limbs, ma'am. But in the upper limbs, ma'am, stereognosis, graphesthesia, and baragnosis were normal, ma'am, in upper limbs.
So after examination?
Cerebellar test, ma'am. Finger nose test, it was positive bilaterally, ma'am. Dysdiadochokinesia present bilaterally, ma'am. Intentional tremors were present, ma'am. Fast pointing was present. Heel knee shin test was present, ma'am. Tandem walking, it could not be done, ma'am, because the patient has difficulty in putting the feet together, ma'am. And rebound phenomena was not present, ma'am. His gait was normal initiation, wide waist, high stepping, looks down while walking, and regular stride with path deviation with swaying to either side, ma'am. And Robert's test, Robert's sign cannot be tested, ma'am. There were no any involuntary movements at rest, ma'am. And Hermit's sign was negative, ma'am. And there were no any signs of meningeal irritation, or peripheral nerves were not palpable, ma'am. And skull and spine examination normal, ma'am. There was no kyphoscoliosis. Other system examination was normal, ma'am. GI, cardiovascular, respiratory, there was no abnormality.
So before the provisional diagnosis,
Yes.
now what additional points you got? One, there is definite evidence of cerebellar involvement.
Yes.
Second,
Second,
definitely there is an extracranial involvement. The extracranial involvement is neurological and non-neurological.
Yes.
The neurological is one, you have got a proprioceptive impairment,
Yes.
but it is not showing the typical glove and stocking pattern,
yes.
but it is associated with areflexia.
Yes.
So it can be either in the cerebral spinal cord or in the peripheral nerve, but in the absence of classical peripheral nerve distribution,
Yes.
in this condition, it is difficult to say where there is associated areflexia.
Yes.
So there is a intracranial cerebellar, definitely cerebellar, because so many things are intracranial. Second, proprioception.
Yes.
Third is areflexia.
Yes.
Fourth is systemic involvement in the form of skeletal. Then as you have clearly picked up, you have to say, so now this looks like a cerebellar involvement
Yes.
plus involvement of upgoing plantar. So
Yes.
upgoing plantar, proprioceptive involvement indicates spinal cord.
Yes.
So you got spinal cord involvement, you have got cerebellar involvement, you have got areflexia, and you have got skeletal involvement.
Yes.
So this is again a spino-cerebellar, whether it is Friedreich's or non-Friedreich's. That is the question again. And how to differentiate. Areflexia is the feature in early onset, and areflexia
Yes.
is favoring Friedreich's. So other ataxias with present with areflexia, what are they? As you have clearly said, vitamin E deficiency ataxias.
Yes.
They are large inherited vitamin D deficiency ataxias. They are acquired vitamin E deficiency ataxias. There, inherited vitamin E deficiency. They will have malabsorption like features. They will have pigmentary degeneration of the retina. They have deafness and areflexia. They respond to very high dose of vitamin E. Then you have got Rousey-Levy syndrome, where it is predominantly sensory ataxia. So attempt ataxia with areflexia. One is vitamin E deficiency. Second is Rousey-Levy syndrome. Basin-Condic disease. Also, they have pigmentary degeneration with ataxia. And okay, subacute combined degeneration of the cornea I will not consider.
Okay.
So after the examination, I will try to tell the structures involved. Always tell the structure involved.
Yes.
So clearly tell that you have no choice at all. You have got cerebellar involvement.
Yes.
So many of these things get struck off.
Okay.
There is definite evidence of spinal cord involvement. That is upgoing plantar.
Yes.
And you have got proprioceptive involvement. In this case, you are typically not able to fix it in the column, because in the column reflexes will be preserved. But when there is both involvement of the root entry zone and the column, that is what happens in this case. Root entry zone and the column degenerates, so the reflex goes up. That we know. But there is a more stronger hard sign in favor of column, that is upgoing plantar. So definite spinal cord, definite cerebellum, plus extra-axial feature. That will not, so even though you, for the sake of a postgraduate discussion, you will say, I am very happy now, I have arrived at a location where there is an ataxia with areflexia.
Okay.
But other ataxias with areflexias do not have pyramidal tract involvement. They do not have skeletal involvement. So this will have not much differential diagnosis. No? So you will say that finally these are the structures involved with areflexia. So you got ataxias with the hyperreflexia, you have got ataxia with normal reflexes, and you have got ataxia with areflexia. Who classified it like that? There's a Sid Gilman. Like what I told, clinical classification very useful is modified Greenfields.
Yes.
Another classification which is very useful is ataxia with areflexia, Ataxia with hyperreflexia. Under hyperreflexia, got the Charlie-Wachsika syndrome, which is common in this age group. Small children, it starts symptomatic. Ataxia, telangiectasia. They all start in this age group only. No? So that is ataxia with hyperreflexia, ataxia with hyporeflexia, ataxia with normoreflexia. That classification is by Sid Gilman. So you get one extra point. So my patient is ataxia with areflexia, but upgoing plantar, supratendorial cerebellar involvement, and skeletal involvement. Removes most of the differential diagnosis I have put. So this qualifies for a typical case of Friedreich Ataxia. Okay, then what other investigations you did? Cardiac evaluation and all you did?
Yes, ma'am. Routine investigation biochemistry was normal, ma'am. His sugars were impaired, ma'am. Both fasting, random, and postprandial sugars were impaired, ma'am. And his HbA1c was also 6.8, ma'am. Apart from that, CBC, complete blood count and liver function test and RFT were normal, ma'am. And HIV, HbA1c, anti-HCV, and VDRL were negative, ma'am. And his VLDL was 38 mg per DL, ma'am. It was also within normal limits, ma'am. And his vitamin B12 was normal, ma'am. And vitamin E levels were normal, ma'am. TSH was normal, ma'am. And 2D echo was done, ma'am. All cardiac chambers were normal, ma'am. And valves were normal. And ejection fraction was 60%. There was many.
So cardiac involvement is not there. Hyperreflexia is there. No, hyperglycemia is there.
Yes, ma'am. And for the similar complaints, he has one MRI in 2013, ma'am. MRI brain was there, ma'am. There were no significant intracranial abnormality, ma'am, in that MRI. And he had an MRI in 2018, ma'am. In that, brain was normal, ma'am, and mild reduced average AP diameter in cervical spinal cord, thinning or atrophy of cervical spinal cord.
What do you think about that? Very typical, no?
Yes.
Friedreich Ataxia, you do not find cerebellar atrophy.
Yes.
And you find only cord atrophy.
Yes.
So that is also very much straightforward case, it looks like, clinically and radiologically. Okay?
And nerve conduction study was done, ma'am. It was pure sensory axonal type of polyneuropathy was there. Motor nerves were normal, ma'am. Sensory axonal type of neuropathy was there.
You will not consider any tendon transfer and all. It's a progressive condition now. So why you will consider tendon transfer? Tendon transfer surgery and all will be considered if you have a non-progressive condition. Progressive condition, those things are not indicated. Of course, you will give him shoes. It's a mitochondrial oxidative phosphorylation defect. So here what you can treat is, you can treat the hyperglycemia. You can regularly follow up the patient for cardiac involvement. So when there is a cardiac involvement, you can try to tackle that. You can tackle the deformities. Those are the things you can do. And people used to, many mitochondrial cocktails have been tried, but mitochondrial cocktails are useful only in the encephalopathic forms of mitochondrial disease. In this type of progressive disease, in fact, a mitochondrial disease, mitochondrial oxidative phosphorylation defect is there in Friedreich Ataxia. And you have got, of course, the frataxin deficiency, but this will not respond to mitochondrial cocktail. Here you look for the cardiac problem which can produce fatal complications, correct the hyperglycemia, and help in assisted ambulation. Anything else you have found, ma? That's all?
I have a video, ma'am, is walking.
Yes, sure. We'll analyze his gait. Good, ma, you seem to have read well, and
Yes.
I think you answered most of the questions. That is nice. So how do you describe his gait, ma?
Wide based, ma'am, and
So by what criteria you feel it is wide base?
his interfeet distance was more than 10 centimeters, ma'am.
Yes. More than 1 foot of any individual, like that you can take, because he seems to be very big built person. So a small built person, their own feet can be used. Of course, you have got the gait scale where you can do the length, height, weight assessment and the proportionate pace. But generally, this is more than 1 foot, so it is definitely weight based. Play it once more. No? His head is fixed on the floor.
Yes.
Agree? No? He's not stamping anything. Seems to have a toe first gait.
Yes, ma'am.
Normally it should be. So if you want to learn to describe this person's gait, you can say it is broad based. It is not heel first, it is toe first.
Okay.
And a slight bizarre character is there. He seems to have some kind of a bizarreness in the gait. So that indicates sensory component, and his eye is fixed on the floor. And play it once more. Let me see what happens to the upper limbs.
Yes.
Upper limbs are all right, I think. But arm swing is not that good. But
Yes.
Arms are held a little away from the front. That is one balancing tactics. When there is an imbalance, generally they balance by holding their hands apart.
Yes.
That's what is happening. So it's clearly sensory component evident.
Yes.
Toe first, broad base. So you'll say broad base,
Yes.
broad base, toe first,
Toe first. Yes.
with the sensory component.
Okay.
Fixed gait. Okay.
His speech.
Their classification, it will come under which one? It will come under middle level. Middle level gait disorder as evidenced by cerebellar component. And there is some lower level component as evidenced by toe first gait.
Okay.
Middle level will be the sensory and the cerebellar, and the lower level will be the toe first.
And his speech also I had one video.
Yes, sure. Ma. I'm not here. I think it is not audible. I'm
Is it
not
not-
able to hear his voice.
Oh,
Only his lip movement I am seeing.
once I will introduce it.
Somehow I'm not hearing. Maybe some problem in the transmission.
He was not able to repeat simple phrases, ma'am.
What phrases you use for eliciting ataxic speech?
British Constitution, I made him to say.
British Constitution is ideally for spastic speech.
Yes, and
There the syllables will run into one another and they will say British Constitution.
ma'am.
That is for spastic. For cerebellar, you can use Chakravarti Rajagopalachari. He was the Governor General of India. All of us know him. So it's a very big name. So we use Chakravarti Rajagopalachari. So
And Thiruvananthapuram.
This one, ma?
Thiruvananthapuram, I made him to say. He was not.
Yes, you can use Thiruvananthapuram. We use some Malayalam things also, but Chakravarti Rajagopalachari is a global person.
Yes.
That is very easy. We just Chakravarti, like that they will split. Okay. I did not hear it, so I cannot tell. Good, ma. Good. It's a typical case. We bring some atypical case also, and then it will be a challenge for us to make a diagnosis. Thank you, ma. You presented very good.
Thank you, ma'am.
I always tell that your case diagnosis is maybe straightforward, but
Yes.
we go through the case so that we follow a mathematical principle which can be applied for many cases that we see.
Okay.
Good presentation. Pass your exam, final year student. Na? Very good. After passing, you announce to us, so we'll be very happy.
Okay. Thank you.
We'll eat our chocolates in our homes.
Okay.
Thank you. Any
Thank you, ma'am.
questions?
Madam, one question from Dr. Aditya. Fox-Marie-Chavani syndrome is a clinical manifestation of ataxia or not? Is the doubt
Yes,
there?
yes. It's an ataxia, early onset with hyperreflexia. It is one of the common ones. like Friedreich Ataxia, which is the common ataxia with areflexia. Charlie-Marzigani is one ataxia with early onset with retained tendons.
Yes, madam.
It is not uncommon. Relatively,
Same follow-up of that same question they asked, can these patients develop myoclonus and dystonia?
you see, you have got ataxias with extrapyramidal involvement, but not Friedreich's. Ataxia with extrapyramidal involvement, so many are there on the SCA subtypes, and you have got ataxia with extrapyramidal involvement in the MSA combined varieties, MSA P plus C, and other SCAs of then you have got Dentate, Pallidoleucian atrophies, no? Then you have got Wilson's disease, Westball variant of Huntington's. All these conditions you can have a combination of extrapyramidal plus cerebellar, but not the Friedreich's ataxia very unusual. Anything else, ma'am?
Yes, madam. They asked regarding the same that syndrome, Fox-Mary-Chavani syndrome.
No, that is not uncommon. How this patient develop Wilson's disease. This patient will not develop Wilson's disease, but Wilson's disease patients can present with extrapyramidal, they can present with cerebellar, they can present with bone involvement, they can present with muscle involvement, they can present with systemic features like renal complications, hepatic complications, anemia. So Wilson's can present with any UMN element. That is why any ataxia, do not forget to look for KF range. It has a multivariate presentation. So always do not forget cataract, Wilson's, very easy to pick up. You will give them a diagnosis. No? So it can present cerebellar involvement, it can present with extrapyramidal involvement, it can present with muscles, joints, bones, tendons, liver, anemia, everything. Eye of the tiger sign. It is seen in neurodegeneration with brain iron accumulation. It is a spectrum disease. It can present with extrapyramidal dystonia. It can present with neuropsychiatric syndromes. It can present with dementia. It can be early onset. It can be late onset. So it's a group of disorders by themselves. And I have seen families where some of them are with a psychiatrist with a lot of neuropsychiatric symptoms. And when they develop extrapyramidal or dementia features, we see them. And so it's a wide spectrum. Anything else?
No other questions. No other questions, madam. Thank you so much for always taking your time out, precious time, almost like nearly 2 hours.
Because you told me to prepare for moment thought. Actually, I had prepared. Because last class we cancelled. I feel sad because I am old now. How long I can interact with all of you, I do not know. I retired 2 years back. So that is there. So I had prepared because that small boy had agreed and taken a case and it presented very well. It is nice because theory part you can always read from the books. Theory is not completely translatable to the bedside. The practical approach is different. That only you need teacher. Theory you have got so much access to so many things. So that is what. Thank you. I am old.
Thank you so much, madam. Every time we listen to your class, we are inspired to read and understand better. And everything makes like sense, like how you said, like mathematics, exactly it fits into that particular position exactly.
Like that, but you
we hope to like continuously present more and more like atypical cases also.
Yes.
I will try our best, madam.
Thank you. Thank
you so much.
Thank you. If there is no class, I am ready with the movement disorder for next week.
Yes,
if there is a case, that will be the priority. Case will be the priority.
Yes,
but we will not break it because I want some 3-4 days to prepare. That is the thing.
Okay.
Yes.
Now this is ready. Movement disorder is ready. So definitely next week class will be there, whether you are taking a case or not taking a case. So thank you so
Thank
much.
you so much, madam.
Thank you so much, ma'am.
Good night.